Welcome and thanks for joining me and my colleagues. My name is Jenny Denford. I am the Central and Eastern Sydney NDIS Transition Lead here at the PHN. Welcome to tonight's webinar on supporting, testing and treating people with intellectual disability through COVID-19. I would like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. We recognise their continuing connection to land, water and community and pay respect to elders past, present and emerging. We also extend that respect to any Aboriginal colleagues who may be joining us today. I'd like to remind you the coronavirus page on the Central and Eastern Sydney PHN website contains links and resources to support general practice, including all the latest updates. If you have any questions or would like additional support, please email coronavirus@centralandeasternsydneyphn.com.au. Central and Eastern Sydney PHN also has intellectual disability web pages for GPs, allied health and community with a list of resources which is regularly updated. This webinar will be uploaded to the intellectual disability web page. We also facilitate a disability network held 6 times a year. If you would like to become a member of this network, please email myself, j.denford@cesphn.com.au. I would like to now introduce you to Dr. Jacqueline Small, Senior Staff Specialist, Disability Specialist Unit, Specialist Team for Intellectual Disability, Sydney Local Health District. Over to you, Jackie.
Thank you, Jenny. Thank you to the organisers for making tonight possible. It's great that this is bringing together GPs and those of us in the local health districts. I'd like to please ask you to please submit your questions by typing them in the questions tab on your screen. Questions will be answered at the end of each presentation and will allow additional time at the end of this whole session for questions to be directed to any of the speakers. If you are having difficulty with the audio or video, please check your settings and connection. At the end of the session, you'll receive a link via email to the online evaluation form, and we do consider that your opinion about how this has gone is very important. Once you've completed this, you will receive a certificate of attendance. So, over to the slides. And if you haven't received the slides, I'm sure that we'll be able to distribute these after the session. So we're speaking tonight about COVID-19 and particularly prevention and management in relation to patients with intellectual disability. You'll be familiar with this COVID icon that is used increasingly around the world to show what is a unique virus. So I'm the first of 3 presenters to speak about different aspects of management of coronavirus for general practitioners. So by way of introduction, I'd like to just reflect on the fact that COVID-19 is a global pandemic. So while since I completed this slide, the number of total cases in Australia and total deaths has not changed very substantially, but it's quite different in some other countries around the world. USA is now above 80,000. UK has risen by another couple of thousand, as has Italy. What is remarkable is the shape of the curve that is also well known, has been publicised throughout Australia, and that is a very nice U-shaped curve with a persistent low rate of infection and COVID cases. What is still being impressed on us by the leaders who have been managing us through this crisis is that there could be a second wave, and that risk has not passed us yet. So this session remains even more timely for those of us who are really concerned about and want to advocate for improved health for people with intellectual disability. So just to capture some of the key features, it was first reported in December 2019 in Wuhan in China. And the symptoms, as we know, range from mild illness to pneumonia. What has been striking is that partway through the illness, some people may become unwell extremely quickly. You'll be familiar with the common symptoms and also aware that many people are asymptomatic. We know there are a number of different mechanisms that the virus can spread, but typically this involves some close contact with an infectious person although it may arise in the 48 hours before they become symptomatic. Mainly, the transmission is via droplets from a person's cough or sneeze, but also by touching objects or surfaces, and then particularly touching your face. We're not going to spend much time on the disease in general, but we'll focus on the relevance for people with intellectual disability. People with intellectual disability are at increased risk from coronavirus, from being infected with coronavirus, and from potentially having more severe symptoms. We are fortunate in Australia at the moment that there have been very few cases of people with intellectual disability contracting coronavirus, but nonetheless, the risk remains. People with intellectual disability have been shown to be at risk of increased mortality, increased mobility, and to have significant barriers to healthcare. And this is particularly an issue for community-based care and particularly primary healthcare. Professor Julian Troller has been quite remarkable in generating an evidence base that will hopefully continue to drive systems changes in New South Wales and nationally. He has shown that the median life expectancy for people with intellectual disability is 54 years, some 27 years earlier than the general population. 38% of that excess morbidity is due to preventable health problems. We know that people with intellectual disability have many times more the number of medical disorders than the general population, many of which are undetected unless systematic mechanisms are used to do so. They are at increased risk of cardiovascular health problems, respiratory problems, and these have been shown to be also contributing to increased risk of serious illness for people through coronavirus. People with intellectual disability have also been shown to have limited access to primary health care, but increased use of emergency department, probably contributing to some of these chronic health problems being undetected and not satisfactorily treated. There are a range of social and behavioural factors that also lead to increased risk for people with intellectual disability, and some of these will be picked up later in this session by Dr. Adrienne Keller, who's a psychiatrist, and we'll be focusing on mental health of people with intellectual disability. There are a range of factors that include the need for multiple carers to often be involved in attending to the personal care needs for people with intellectual disability. There may be multiple carers visiting and supporting a person on a daily basis. And certainly for young children or children at school, often they require fairly close, intimate support from their teachers and other staff at school as well. People with intellectual disability may live in congregate care settings or else live at home, and these congregate care settings may also prove an increased risk, as we've seen particularly in the aged care sector, where there's been rampant coronavirus outbreaks in some situations. I'll skip past the increased mental health and the challenging behaviours because I know Adrienne will focus on those, but they are a particular issue during crises and pandemics such as we're currently experiencing. The hygiene of people with intellectual disability may be compromised because they're often requiring support from other people for these needs, but they may also not understand the need for blowing their nose, wiping their face, and using the enhanced hygiene approaches that are currently being advocated. People with intellectual disability have communication limitations. This can have an impact on their understanding of what people are communicating and communicating their own particular needs. This can lead to reduced expression of symptoms that they may be experiencing, concerns about how they're feeling, what they want and need, and difficulty understanding the directions, particularly as they've been rapidly changing over the last few months. Many of people have experienced difficulties with accessing the internet and technology that has been a bedrock of the healthcare delivery system over the last couple of months in order to maintain safe delivery of healthcare. This has been an added barrier and inequity for people with intellectual disability. Some of the self-isolation has been occurring for people with intellectual disability, and sometimes they have been shut in their own room or in their own home without access to the usual support, and all living in closed settings. This is an increased risk that their basic needs may not be met, or contact with other people. There are other factors that can lead to significant added stresses for people with intellectual disability. Care and mental health, and I expect Adrian will also pick this up. We've seen dramatic changes in the workforce and loss of work for many people, particularly in the service sector or in the hospitality sector. This type of workforce change may have a disproportionate impact on people with intellectual disability who are already at an added disadvantage due to socio-economic inequities. There's been loss of work and income and increasing working from home, disturbing the daily routines and disrupting the usual forces and work stability that people experience. The schools have mostly been closed, but there's been inconsistency, particularly for children with disabilities. And re-engaging in school presents particular challenges in order to maintain hygiene and keep those children with disabilities safe, particularly if they have increased risk, such as children with Down syndrome who may have compromised immune system. Social distancing has been an issue with closure of centre-based services that disrupts daily routine and withdraws the familiar people who are supporting people with disability in everyday life. The transition to online and telehealth delivery I've already mentioned. There has been limited access to our community for all of us, but there are some exceptions to the general public health measures that would allow people with intellectual disability to continue to be supported by their carers, and this may not have been well understood. So it is our responsibility, I believe, to provide enhanced and tailored support for people with intellectual disability during this period of time. The main mechanism that is used to support people with intellectual disability is to implement reasonable adjustments. So in Australia, we don't mandate these, but it is important that we become increasingly aware of what reasonable adjustments are in order to better support people with intellectual disability and to ensure that they are able to access the health system in a way that best meets their needs. So I like this description of what reasonable adjustments are, and it comes from the link below, which was a guide established in the UK to support general practices making reasonable adjustments in primary health care. It's quite an extensive page, and I'd really encourage you to have a look at it to get some other ideas of reasonable adjustments that can be made. These are small changes that allow fair access, equitable access and treatment for people with intellectual disability who may require extra help. So some of these may actually require changes to the usual booking practice, etc. And I know that can be quite complicated, but perhaps at a policy level, we ought to start thinking more seriously about that. But there are other things that can be done reasonably easily. So this might include, for example, a practice register of patients with intellectual disability in order to target them and identify what their special needs are and reach out, perhaps at a time of coronavirus, to ensure that they have the support that they need. I know Nathan will talk further about tips for GPs who are supporting people with intellectual disabilities through this period. Another idea is to ensure that the appointment letters are in easy read format and there may be reminder telephone calls the day before an appointment or a text message reminder. People are looking to develop apps that may better support delivery of healthcare, including prompting about health promotion and health prevention strategies that will be better able to be accessed and used by people with intellectual disability. It is also important to ensure that written information and the health professional is able to communicate with a person with intellectual disability in a way that they can understand. So there's a variety of augmented and alternative communication strategies, some of which are quite complex, but others can be used in a simple way to support our interaction. I would also commend to you some excellent resources that are available on the Intellectual Disability Health Network that's part of the Agency for Clinical Innovation. And if you Google the ID network, you'll find a whole suite of resources that will be very helpful for you in your practice. Some of these include videos to support people with themselves, training videos for health professionals, and other tips such as ways you can modify appointment letters, etc., as I've suggested. It also includes information about Say Less, Show More, which is a strategy I've been involved with to provide visuals that help communicate with people with intellectual disability about some common interventions that they might experience in health, such as seeing a dentist, a physical examination, or having blood taken. Using these are simple, cheap, and an important and valuable way of providing tailored and supported healthcare. I would commend to you a document that is available on the Department of Health website, Management and Operational Plan for People with Disability. It has a wealth of resources. The principles on which this is based are equity, prevention, informed, targeted, support networks, partnership, and cultural consideration. The human rights of people with intellectual disability should be upheld through an equitable, accessible, and tailored healthcare response. We need to ensure that people with disability are prevented from becoming infected. We need to ensure that they and their families and carers are informed about what to do. We need to provide clear and targeted information and programs to support them if they become infected or unwell. We need to ensure that their support networks are able to be maintained through this crisis. Working in partnership across health and disability and other sectors is becoming even more important, and something that I see has been a profound change through this last period. We also need to recognise the cultural consideration, and particularly as that's relevant for Aboriginal and Torres Strait Islanders, and ensure that there are adjustments made to support them in a way that is more appropriate. So just some specific areas about this COVID-19 plan. I'd like to particularly draw to your attention that there's been efforts to prepare the disability sector and workforce. And the NDIS webpage has got a lot of extremely helpful information that you can provide to the person with disability and their carers, or even the disability sector, to ensure that they are well informed. This discusses the availability of personal protective equipment that in part they might need to source themselves, but if they can't, the national stockpile is able to be accessed by the disability sector, and it is being accessed by the disability sector. Social distancing is expected to occur within all disability services, and it's important that that is recognised in how the disability sector and health sector works with people with disabilities. Tailored communication has been made available for people with intellectual disability, and one of those examples is the picture on the bottom right of your screen. It is vitally important that healthcare plans are developed through this period for the event that the person may experience coronavirus, but also importantly in relation to any of their ongoing health needs. It is important that the disability sector does ensure that they wash their hands properly and maintain an extremely high level of hygiene in order to keep people with disability safe. There's a variety of training videos and resources that are available, and there's just one example here on your screen. There are also careful plans being developed in the event that there may be a suspected or confirmed case. I know in our local district and in southeastern Sydney, you'll hear more about that later. The disability specialist health staff are looking to support the activities of the public health activities of the district and any resultant need for clinical support as well.
5 minutes, Jackie.
Thanks. The same principles that apply for the general population apply here about early detecting testing and isolation. There are a variety of easy read resources, and I would commend these to you from the Council for Intellectual Disability. There are also increasing resources being made available by the Federal Department of Health, and I know that that website is here somewhere in the presentation, and more will be added over the next couple of days. This COVID-19 infection control training video is also a very worthwhile video and is being accessed widely by both the health and the disability sector. There are significant changes to the NDIS sector, and this web link is where you can go to find specific information and where to go if you have other questions. I'm very pleased that the local group homes have been well prepared, according to a conversation that a social worker who works with me has had in the last couple of days. But there has been significant changes and adjustment in the disability sector to respond to the crisis and trying to maintain service for vulnerable people with disability. So this is the web link for national coronavirus information, and again, there's a lot of information. There will be a helpline developed, and if you want more information about that, we can discuss it later. There's a general disability information helpline, and I would also commend to you the New South Wales government information that has both a lot of resources as well as a lot of policies that will be helpful for you as you support people with disability. So if there are any questions, I'm happy to take those now.
No questions as yet, Jackie.
Thank you, Jenny. In that case, I'm just going to turn off my video and hand over to Adrian.
Great. Thank you so much, Jackie. I'll have the next slide. Thank you. Okay, so these are the main headings that we'll cover. We'll also cover, which I don't have here as a dot point, the disability response team, which has been developed in the South East Sydney Local Health District, which is where I work as a psychiatrist with the disability specialist disability team, and I'll talk about that as we go. So we'll cover these main topics. First of all, I actually want to talk a bit about what's happening to the mental health in our general community before we specifically move on to COVID. I think that's quite an interesting thing to look at. Then I'll talk about how mental health issues are specifically impacting on patients with intellectual disability. Then look at the issues for those who are living in supported accommodation specifically, because I think that's a particular focus. Although clearly there are also issues for people who are living in private accommodation with families. I want to raise the issue of carer mental health issues as they might be impacting on the person with an intellectual disability, and then some of the challenges with treatment provision. Next slide, please. Thank you. So what is happening during this COVID pandemic to mental health in our broader community? And I'm sure those of you following this in the media would have heard a number of, read and heard statements. And there was a study, or not so much a study, but a report that came out last week, I believe, from Sydney University, suggesting that the suicide rate is expected to go up substantially. I discussed this with some colleagues recently. I'm somewhat sceptical about that, and I'll come to that in a minute. In fact, there's a wide variation in responses in terms of mental health. In other words, it's not all bad. What is happening? Well, the previously well-adjusted in our community, in other words, people who previously did not have any mental health issues or no overt mental health issues, certainly are experiencing, and often for the very first time in their lives, significant adjustment disorders. And many of them are seeking professional help, and mainly in primary care, mainly with you in general practice, not so much with me in a specialist psychiatry setting. However, Many with chronic mental health issues like depression and anxiety are in fact in well-established care arrangements already, and many of them are very stable. They've often had to make relatively few adjustments to their normal lives because they're already socially isolated due to their illness. And a lot of them have developed resilience due to their having to live with adversity for years. So in fact, COVID has not tested them in the way that it has tested many in the community. And I have to say that some of my chronic patients in my private practice are doing better than they usually would. And I don't know what to attribute this to. I've queried there, is it Schadenfreude? In other words, is it pleasure at others' misery? But a number of them have used the phrase, welcome to my world. In other words, everybody else is having to deal with some of the problems that they're dealing with. Social isolation is their norm. It has now become the norm for everybody. And I would note, in relation to the issue of suicide, rates of population suicide will often diminish during periods of extended social adversity, which are also associated with national cohesion. In other words, during the world wars. So I am sceptical about those predicted suicide rates, but we will have to wait and see. We cannot know with any certainty what is going to happen, but I don't think it's all bad. Next slide, please. Okay, so what is happening in terms of mental health in patients with intellectual disability? Well, at one level, many of them, particularly at the severe end of intellectual disability, will be completely oblivious to what COVID is and to its local and global impact because of their cognitive impairment. They simply won't understand COVID. However, at another level, they will be acutely sensitive to changes in their immediate environment. So they may well sense that something is wrong, even if they don't know what is wrong. And we know that persons with intellectual disability or a significant autism spectrum disorder, or both, will often struggle with any change to their usual daily routine. And that means the usual person, the usual place of activity, time of activity, or the type of activity they're undertaking. And it really, because of COVID, it's the abrupt onset of the change, and it's the widespread nature of the change that's been brought about that can be predicted to impact very negatively on many of these patients who have, as part of their illness or as part of their condition, I suppose, a rigidity around the need for structure and routine. The most common mental health response will be an increase in anxiety. And the more challenging behaviours often accompany anxiety. And by that, I mean opposition and resistance to the changes that have been put upon them. And we often see aggression, which can be aggression to property or aggression to other people, and self-injurious behaviours, headbanging, cutting, biting, etc., yelling. Next slide, please. Yeah, thank you. So what about people who are living in supported accommodation? Well, they're often subject to greater restrictions in this kind of environment, and because they're multiple vulnerable people are housed under the one roof. As we know, in group homes, there are often 4 or 5 people living together, being cared for, who all are vulnerable with disabilities. We also know that many day programs have closed, often for an extended period, and this has led to residents having to spend time together at home. And I've certainly been aware through my clinical contact that this can inflame existing tensions. So we often see in group homes that a couple of residents just don't get on with each other. But because they've had to spend increasing amounts of time with each other, it's led to incidents of aggression between these residents. It can be quite often difficult to supervise community access with these client groups. I've had a few patients who've told me, I really want to go to the shops. I love to go to the shops. But there's increased risks of viral transmission both ways, both between the patient and the community and the patient. So that, and quite sensibly, this group cannot be taken out in the community where they're exposed to other people. They can go out, of course, one-to-one for walks and exercise where they're not exposed to the community, but where they like to go out for shopping, etc., they simply can't go. Also, we've had the issue, which may be starting to unwind a little bit now, but certainly for many weeks now, residents have been unable to visit or receive visits from their parents or family due to social distancing. Many patients have extraordinarily strong attachments to their families, much more so than other people of a similar age. And disrupting this routine can be highly distressing, and it can't be easily replaced by video chat, as with other people who don't have a cognitive impairment. So I think this is something that needs to be factored in as a very important issue. The other thing is the use of touch can be very soothing and appropriate for people with an intellectual disability. And although this can continue to occur within a family home, where it can be appropriate and is not sanctioned due to WHS issues or other rules around the COVID restrictions, it is now prevented in a group home setting. You simply can't go and cuddle or hug or lay a soothing hand on somebody with intellectual disability because they're distressed. And that is making it very difficult for somebody who's highly agitated or anxious. Next slide, please. What about carers? Well, first of all, if we're talking about carers in a private setting, for somebody who's living in a private home, the parents who are carers, what's happening there? Well, there's a further increase on existing significant burden of care. They're dealing with their own issues, which might be job uncertainty, job loss for some of them, or the whole issue of working from home, which can be very difficult. As we know, many carers are elderly. Many of my patients themselves are in their 30s and 40s or 50s, so their parents are necessarily going to be quite old and in the high risk group for COVID. So they're worried about COVID for themselves as well as their child. And there's a lot of uncertainty about disability and health service provision. How do you access disability care at this time when programs and respite services are shutting down? And what about health services? Can you turn up to the doctor? Do you have to do it clinic by phone or video? What's going to happen? And when will things go back to normal? Next slide, please. The issues for caring for a person with disability in a group home is really about the professional carers. So we know these environments are already high stress. They're difficult environments to work in for disability support workers. But there's been an abrupt change to practice and process. So much greater face-to-face time is now required. Rather than the clients being able to go out for 6 or 7 hours during the day to their day program, they're now in lockdown for the whole time, 24 hours a day, unable to attend the programs, unable to often to have community access. There's a lot of anxiety regarding these strict COVID regulations. The workers themselves, they fear attending work if they have mild symptoms because it could contribute to an outbreak in the home. We've already seen in aged care facilities the impact of workers turning up with mild symptoms in some of our aged care facilities where many staff and patients have contracted the illness and many people have died. So this fear is real. But on the other hand, you've got the feelings of guilt if you don't come to work. What if you're completely, well in every other respect, but you've got a sniffle and you don't go to work, but everyone else on the team is having to carry the extra load. So that can lead to feelings of guilt. So this is a really difficult situation for care workers, not to mention the changes in practice that have been brought about through increasing focus on hygiene issues, use of personal protective equipment, the way that they handle clients. Clients are still needing to be washed, bathed, toileted. These issues place enormous stress on professional carers who need to be following regulations and are terrified if they do something wrong and a case breaks out that they could be blamed for it. So I think this is very, very difficult for them. Next slide, please. So what about treatment provision? And this is particularly, I think, important as GPs to consider. How do you deal with treatment that might present itself? Well, first of all, I think we need to expect some degree of fluctuation in the clinical state of people with a disability during this difficult period. So what happens if a professional carer or a parent brings a person with a disability to you during this period? I think, first of all, we need to avoid the temptation to chase a solution as a kind of a knee-jerk reaction by increasing or adding new medication to try and help things. I think it's really important to just take a step back, consider what's going on and expect that there will be fluctuations, and that simply trying to chase a solution by adding medication may in fact cause more harm than help. However, it is important to maintain contact with carers. Phone contact will often be adequate. Certainly I found it to be very adequate with my patients and carers, particularly where a pre-existing relationship exists and you don't need to see them face to face. You don't need to bring them in person. You don't even need a video contact. A phone call is often enough. It's important to promote stability during times of extreme change and instability in so many other areas of our life. So that means continue with usual medications. Ensure that the group homes have a regular supply of prescriptions to the pharmacy so that there's no risk that people will run out of medication. Encourage carers to maximise the routine and structured activities as much as possible, even in these difficult times, so that where there's so much instability in other areas, where stability can be promoted, it should be. Always seek specialist advice where it's indicated, and that includes a service like mine, a service like Jackie's, and we do, you're lucky to be able to access these services when you work in an area like CESPEN covers. So please, if you feel like a specialist assessment is required, then make that referral, but do it judiciously with clear questions in mind. So what is the issue? In other words, you've tried maintaining current medications, you haven't jumped in early, but it's simply not sufficient to manage behaviour that has arisen, and you feel that a specialist review could be indicated to help you to manage your patient currently. Next slide, please. Can we move on to the next slide? Thank you. So now I just want to talk a little bit about the disability response team in SESLHD in South East Sydney. So we've partnered with the Disability Strategy Unit, as well as the COVID testing clinic and the Public Health Unit to provide a disability response, which is really the aim is to minimise spread of COVID amongst people with significant cognitive disability as well as physical disability, and to prevent them from, otherwise prevent them from accessing mainstream services. So we've pulled together to with resources from the Public Health Unit, medical, disability medical staff, nursing and allied health staff. So we're providing information around COVID, both to people with a disability and their group homes. We've conducted already some webinars which have been very successfully and well attended. We're assisting people to access COVID-19 testing where required. And it's supportive of their particular complex needs, including a pre-test risk assessment to determine if the test is required. And we're also dealing with an incident management response when people are identified in disability group homes. Fortunately, there haven't been too many people identified to date, but we do have a response, a management response where such an incident or such a case is identified. Services requests can be made through the Public Health Unit, either from a person with a disability, their carer, or a GP, or the group home, or any health staff. So we have a broad base to receive referrals. Thank you. I'll take the next slide, which I believe is my final slide. So to be eligible to receive the service, you need to have a significant cognitive or physical disability, which will prevent your access to mainstream services. Complex and chronic comorbidities. You would be unable to attend the clinic due to the likelihood of significant stress to the person. And I think we would all appreciate that coming to a mainstream service would be highly challenging and stressful for many of our patients who have a significant disability. Challenging behaviour would obviously be an indication and could cause enormous difficulties within the mainstream COVID clinic. They need to be over 16 years old, and the usual COVID testing criteria would apply, and the requests can occur 7 days per week on that number. I believe that's my final slide, and I don't know if we have any questions at this stage. Any questions?
No,
yet?
No questions at this stage, Adrian.
All right, well, I might hand back to Nathan or back to Jackie as chair.
Great. Well, thank you very much to Jackie and Adrian for their presentation and information that they presented this evening. And I'm going to just try and bring together just the presentations and bring a general practice perspective, looking after our patients with intellectual disability. And so I might just go to the next slides. And I think just really in terms of what we'd like to try and do for our patients is to continue with usual care. And of course, that's difficult under the current circumstances. And we do know that many people who are in our community are avoiding routine care at the moment, particularly for chronic disease management. And we don't want our patients who do have intellectual disability to miss out. And so I think it comes to the next point about looking at what the options are to deliver that care. And of course, we're aware that there's been a lot of changes in this space. And of course, relating to telehealth, and of course, the changes to face-to-face interactions as well. And regarding telehealth, I think it's important that we try to inform the patient and the carer as much as possible about what that means, because there are the video conference or the video calls. And the benefits of that are the non-verbal cues, the facial expressions and the behaviours that we might be able to, that we might be familiar with when the patient is with us in our rooms. And I think that might be missing, unfortunately, in just using telephone. But however, some patients may prefer telephone. They might be used to that, and that might be an optimal way of delivering care. So it's about trying to figure out which of these modalities is suited to the patient, but also their carer as well. And then with regards to face-to-face, I think that's, because of the changes to the flows of general practice, this might require some screening to be done beforehand, or might even have a preceding telehealth consultation to determine the safety and also suitability for a patient to come to practice. So I think that might be something that the patient and the carers should be aware of. And also in terms of the timing in which we deliver the care as well, because they might not be able to come in at the time that they would normally be able to, because of the ways that general practices are scheduling face-to-face interactions maybe towards the end of their sessions in the morning or later in the afternoon, after having done maybe the predominant amount of their consultations via telehealth. So I think in terms of the building on communication aspects, I think that when we're engaging with the carers, we might even look at more broadly the other people involved in the person's care, and that would include the home and community service providers or education providers, and most certainly their allied health professionals who are involved. Now, trying to undertake a case conferencing at this time where we might have a bit more availability because of just reduced traffic coming into the practices, but it might not apply to all GPs. But I think that if we are able to try and bring together the teams who are looking after our patients with intellectual disability, this might be a great opportunity for doing so. But bearing in mind that our allied health professionals may not have the same access or do not have the same access to NBS benefits for their time in participating in a case conference. So I think that could be rather unfavourable for them, but certainly if they are able to participate, and I think that would be very ideal. And I think in bringing together the team, it's about trying to look at their plans and looking at what their goals are. Things might have changed as a consequence of the changes in our community and to programs as a result of COVID-19. And I think with respect to those who are on NDIS plans at the moment, then this might also present as an opportunity to go over that and bring together the team members who are participating in that patient's care. So the next thing as part of the care we can provide for our patients would be to encourage and to check on their vaccination status, particularly as we enter into the influenza season at the moment. There's a high demand for influenza vaccinations at the moment, and we do know that the supply of the standard influenza vaccination is quite low, and I do understand that in our district it might be even only coming up towards the early or middle of next month. So there are some limitations, but for our paediatric patients, I do understand that they might still be readily available, and so that might be a good opportunity to try and engage with our younger patients and their parents and families to try and get them vaccinated because of the fact that they may have other comorbidities, they are at higher risk of becoming quite unwell with influenza. So we want to try and get them in and to have them protected as much as possible. And then regarding pneumococcus, of course, it's more skewed towards our elderly patients, but for our Aboriginal and Torres Strait Islander patients with intellectual disability, or just even any other risk factors who are older than 15 years old, and they are eligible for the pneumococcal vaccination, and we would try to encourage that as much as possible. But I think that the demand for pneumococcal vaccination has also similarly increased as a result of the COVID-19 issue. And I think that's it's still possible to have it, but we may encounter problems with the supply coming up. And I think another issue with respect to influenza vaccination is, again, with if we're not able to provide that in our practices, then it might be an option to try and have them go to a local pharmacy or the pharmacy that they are normally attending, and they might be able to access it there. And that could be an alternative if they can't have it done with us in our practices. And then with respect to COVID-19, Adrian and Jackie have mentioned a lot about it. And I think that a lot of us in the community are probably very aware of the symptoms that people would experience that are typically associated with COVID-19, being the cough, the sore throat, the fevers. But of course, it may manifest differently in our patients with intellectual disability. So we want to try and reach out to the patients and to their carers and to inform them about any concerns about changes or where suspecting that they might be having an illness, and to then be able to inform them about where their COVID-19 clinics are, so that they can actually go to those places to be assessed appropriately and in a timely manner. Otherwise, of course, their local emergency department. But there are lots of these respiratory clinics that are popping up, and I think having that resource available and letting the patient and the carer know about that could be very convenient and very helpful. And so regarding medications and changes for those who have particularly gone to hospital, making sure that our records are up to date, and that might also translate to putting that information onto my health record in the event that if any of our patients were to become unwell, that we can have that information readily accessed in other settings, in other general practices, or of course in other hospitals as well. And I think in terms of the care plans, there is the option of updating that, and I think we would try to get that done where possible. Of course, it's now available for that to be done via telehealth, but it might be preferable for that to still be done via face-to-face, but that might just be an issue with respect to negotiating that with their patient and of course the carer as well, or family. So I'll just move on to the next slide. So I guess just in terms of the Medicare aspects or the telehealth items, I think that the implementation of this was 2 months to this date, and it's been rolled out quite quickly. And I think that initially it was targeted at patients who were suspected or who were at risk of COVID-19. And since then, it's been quite, it's expanded quite significantly to be a whole of system approach. And it's allowed GPs to access a lot more numbers, and of course, including those for chronic disease management, mental health care plans, and urgent after-hours services, but also for our other colleagues, medical specialist colleagues, and of course, a variety of other allied health professionals as well. And I think that's been a really positive move to allow us to deliver healthcare, especially for our patients with intellectual disability, who might also have issues with respect to transport and coming into our practices as well. So it's an extremely positive direction, and this may continue, obviously, beyond the COVID-19 pandemic. Next slide. So just with respect to the MBS, or pardon me, Medicare aspects of it, unlike for our medical specialist colleagues, basically for us in general practice, we must bulk bill for the telehealth consultations, and this applies to those with concession cards, those of our paediatric patients, and those who are considered to be more vulnerable to COVID-19. And that's a broad category which includes people with immunocompromised or chronic disease, but also even patients who are pregnant and also those who have young children as well. So if not fitting that criteria, of course, then practices that may charge us as such, they may be able to do that, but probably for the majority of us who are seeing our patients with intellectual disability would probably be most likely to be bulk billing them. And then coming to the issue of patient preference and accessibility, I think I alluded to that in my earlier slide, so I won't go into too much detail, but I certainly think, again, discussing that with the person and or their carer and family is really important before we embark on that. And then regarding privacy and consent, I think those are really important issues to consider, particularly with privacy and the conducting of consultations by telehealth. I think that's we are now, of course, there's a bit of a easing of the social distancing, but of course, for most people, they are still remaining at home for the majority of their day. And that might still mean that, or may mean that they've got still a lot of people within the household, and it might be difficult to have privacy for certain consultations. And I think that we need to just check with our patients and ensure that they are in a space in which they can have a private consultation. But of course, if there is involvement of a family or carer or for a younger patient, then that might not be necessarily a big consideration. And regarding medical records and documentation, as with all of our standard consultations that we would do, when we are performing them with telehealth or via telehealth, then we need to make sure that they are recorded contemporaneously and of course accurately. Next slide. I think that just in terms of wrapping up here, basically there's the NDIS information, which you might all be very familiar with. That's provides you with the item numbers and of course just the ongoing updates that are evolving with telehealth. But certainly a lot of that has again happened in the first couple of weeks. I think from the first week of April it's remained largely unchanged for general practice, but I certainly think that as things continue to evolve, then going back to this reference here with the NDIS online is going to be certainly very helpful. Next slide. And I think with respect to telehealth, there are a lot of practices which are trying to adopt this, and some practices, particularly those in regional areas, might be having a bit more difficulty, with respect to telehealth. And regarding telehealth, the majority of our telehealth consultations have been via the telephone, I think in the order of about 90%. So the rebate, of course, is still the same for both, but there is a tendency to be sticking towards telephone consultations, and that could be a preference that's expressed by GPs themselves or maybe by their patients. But these references and resources are hopefully going to help GPs to take up telehealth a little bit more. And I should allude to the Agency for Clinical Innovation as well, who have a great resource on their website that really walks through practices and gives information about how to adopt telehealth optimally. And I think I'll come to the next slide, which is my final slide. This just basically is our resources and a variety of them published by the Commonwealth Department of Health, by New South Wales Health, and a variety of other non-government organisations and specific associations that might be relevant to people who look after our patients with a wide variety of different types of that disability, but of course with a focus on intellectual disability. So I think I'll leave it at that. I was intending to speak for a lot shorter time and leaving some time for questions, so I should actually just stop and hand it back over to Jackie. And thank you very much.
At this stage, we have no questions. So Jackie, is there anything further that you would like to add? No. Well, I'd like to thank Dr. Small, Dr. Keller and Dr. Lum for taking the time to present tonight. Thank you to everyone for attending. You'll receive the evaluation link to your email box shortly. Please ensure you complete the evaluation, then your certificate will be provided within 2 weeks. Additionally, if you're unaware, we have upcoming education. The Specialist Intellectual Disability Health teams of Sydney and South East Sydney local health districts, in partnership with the Central and Eastern Sydney PHN, have developed a series of 4 accredited workshops. These sessions are advertised on the Central and Eastern Sydney PHN's website. So once again, thank you to Dr. Small, Dr. Keller and Dr. Lum, and thank you for everyone attending, and good night.